Good afternoon, everyone. My name is Rui. I'm a principal biomedical scientist in hematology, that is part of the blood sciences laboratories in Synovis. And today the aim of my presentation is just to speak a little bit about the pathology services that Synovis provides for primary care. And when I mean primary care, I mean for the samples that are referred to us from the general practitioners clinics, and the importance of this service for correct patient management. So during my presentation, I will give a little bit of an introduction on who is Synovis and who we are and what job do we do and what is our mission. And speak a little bit more about then as hematology as part of the blood sciences laboratories and its operation. I'll then describe, do a brief description on the analyzer operating principles. So the analyzers that we use on our day-to-day basis to provide the pathology services that we do. And then I will speak a little bit more in detail about how we go on and do things, and we'll present a couple of practical cases that are from actually real patients that we tested in Synovis, and the difference it made for patient management, that we provided a good service as part of primary care. So talking of Synovis, so who we are in Synovis. So Synovis is a partnership that has been established a few years ago between SynLab and Guy's and St Thomas's and King's College Foundation Trusts, NHS Trusts. So these trusts, they have inside of their structure a few hospitals. So as Guy's and St Thomas's, they have Guy's Hospital, St Thomas's Hospital, Royal Brompton and Harefield hospitals, and King's College has their main site, King's College Hospital, and also the Princess Royal University Hospital. And the role of Synovis, or what the aim of Synovis for the coming years, is to transform what is the existing status quo of hospital-based laboratory and diagnostic services, and transform this existing structure into a hub and spoke network that will serve mostly Southeast London. And I will leave just a caveat here. A couple of our sites, Royal Brompton and Harefield, are in a different geographical location in London, but mainly the services that Synovis is providing at the moment, or has been contracted to do, are for the Southeast London area. So for that purpose, Synovis has built a purposely built laboratory, pathology laboratory, which is one of the largest in the UK. And it has been designed to meet all the needs of the modern day healthcare services. And the hub will be our main site where most of the samples are actually going to be processed, and it's already, part of it is already operating. And then we will have the on-site hospital laboratories. So these laboratories, they were the original laboratories that each hospital would have, but now they're being kind of restructured, I can say, in order to provide a more focused service for the patients that attend these hospitals. And I'm talking about patients that go to the A&E, accident and emergency department, and inpatients that are in hospital beds and they need samples with a short turnaround time. So to do so, we're taking away some of these primary care samples from GPs out of those sites, and we will be taking at some point some of the outpatient samples, so we can provide a more focused service, and a service that is focused in short turnaround times. So Synovis provides pathology services across a number of specialties and departments, and these cover several areas of expertise like blood sciences, biochemical sciences, cellular pathology, transplantation, cancer specialist services, and a number of other laboratory services. As you know, pathology provide services for that's a huge catalog of tests, and the best and safest way to provide these services is by having specialized laboratories that each one can develop their own skills and expertise into providing accurate and relevant results for patients. Talking more specifically about the blood sciences laboratories, there will be a presence of a blood sciences laboratory in all sites, either being the hub and the spoke laboratories, and mainly they provide a service for different areas of expertise. One of them is going to be blood transfusion. This blood transfusion service only happens in the spoke laboratories, in the essential services laboratories, because blood transfusion is an acute service that is provided, whose main aim is to provide a rapid response service to patients that might need any sort of blood transfusion. So it makes sense that it's only provided in locations that have patients on site and they need this sort of response. And then we would have clinical biochemistry, hematology, and routine hematology. These services can be provided on all of the sites with different test repertoires offered based on the type of patients that we're actually providing a service to. So in the essential services laboratories, the aim is to provide results to patients for urgent samples, mainly A&E samples, inpatients and outpatients. In the hub, mainly the focus has been on primary care samples, which in terms of numbers, the sheer number of samples that we process, this is the biggest slice of our work. But we also, the aim is to provide service for non-urgent outpatient samples, and we are working towards this transition. We just need to clear a few more hurdles in order to be able to transfer this hematology service into the hub in the safest way possible for patients. The tests that we provide in the routine hematology laboratory, we can say that we don't have the largest repertoire of them all. We provide mainly I don't know, half a dozen of tests, but in terms of volume, particularly in terms of full blood counts, we do thousands of full blood counts across all sites on a daily basis. So it is even though the test repertoire is not really, or the test catalog is not huge, we still provide results for a huge workload in the blood sciences laboratories. So the main tests that we provide are full blood counts, reticulocyte counts, blood films, malaria screenings, ESRs, plasma viscosities, and some more specific tests around specialized morphology services. And these could be urinary hemosiderines, Caesary-like cell counts. But we also provide support to the hematology doctors by performing the staining on bone marrow aspirates that they do, so they can then go and review these slides. As I mentioned to you before, there is this large laboratory that is built in central London in Blackfriars, so it's kind of central to all of our locations. To provide the service that we need to provide, we invested a lot in automation. So we have two massive automated tracks with 5 analyzers each. We're using Sysmex XN10 or XN20 analyzers, and a little bit in a couple of slides I will explain the difference between the two of them, but they have similar capacities. The throughput of each analyzer is about up to 100 samples per hour. So in a day, as you can see, we can provide thousands of full blood count results without any issues in terms of our analytical capacity. A sample volume required to do a full blood count is very little, is less than 100 microliters. So it's even with shorter sample volumes, we can provide a full blood count result. And these automated tracks also have an integrated slide maker stainer, a sample sorter, and an ESR analyzer. So in reality, we can load the sample at the beginning of the track, get our FB full blood count done, get our blood film automatically prepared, smeared, and stained. If there is an ESR, the ESR is done automatically, and the sample is sorted and filed without any need for human intervention. Another of the not automation, but of the analyzers that we have in the hub, and we're implementing it as and we're making great efforts to implement it in the near future, is digital microscopy. So in reality, it will help us provide a better service, because by providing this service digitally, we will be able to be a little bit, to give us some flexibility on remote validation of the films, that you'll have a screen, an image that it will be on a screen that I will show in some of the cases that I will present, that will make our process of reviewing blood films going one step forward, and we will be able to provide a service within the reasonable time frame that these results will need. So talking about our analyzers, so they are the Sysmex analyzers. They utilize the same principles that have been in use in hematology analyzers for decades now. They also utilize the Coulter principle. Obviously, it has been with decades of expertise and technological advancements. All of these techniques have been refined now, so they allow us then to get really accurate results, and with short turnaround times and with a high throughput that these analyzers have. So I'll speak briefly about some of these principles that the analyzers use. So for the measurement of red cells and platelets, the analyzers use this direct detection method by utilizing hydrodynamic focusing. So pretty much what it does, it aspirates a small volume of sample, and it dilutes the sample that is then mixed and put the blood cells in a sheet of fluid that passes, that is then put under pressure, and it forces the cells to pass through the center of an aperture. And this aperture has two electrodes that have some electric current going between them. And as these cells are passing through, it causes an interruption in this electric resistance that exists there. And what it does in reality is, for each event that is passing through, it counts them as one event, and then according to the size of this event, it will then determine some of the characteristics of these cells. And one of the main things is that it will determine is the cell size. So as you can see here in this picture, a red cell, it's larger than a platelet, so it will cause a bigger interruption in this electric current, and what it will generate is an electric pulse that will then the analyzer software will read, and then will use it to plot histograms with information about the cell size, but also it will give us precious information to assess how normal or abnormal these cells can be. Platelets, on the other hand, they have very small size compared with a red cell. So in normal condition, we would see this difference between the cell types. if there are differences in both the sizes of the red cells or the platelets, we might get to a point where there is an overlap between the two populations, and the analyzers will flag us saying that there's something that is not normal. Another part of the full blood count that these analyzers do is to determine the hemoglobin concentration. And to do so, it uses a cyanide-free method in which red cells are lysed, and then they are bound to this sodium lauryl sulfate, the SLS molecule, which then will make a colorimetric complex that is then measured by spectrophotometry at a specific wavelength of 555 nanometers. This again, it takes just a few seconds to do these measurements. And then another of the main parts of the main components of a full blood count is the white cell differential. It is important to know how many white cells are in the cell, and they are counted pretty much also by the same principle as the red cells and the platelets, but on a different channel. But it's also crucial to differentiate between the different types of white cells. And to do so, these analyzers, they use fluorescence flow cytometry, which will then be used to analyze the structural properties of the cells in terms of size and complexity, and then it will then generate an automated differential count, which will then separate the different types of, let's say, neutrophils, lymphocytes, eosinophils. But it will also give us an idea on how normal or abnormal these cells are based on their contents. So these samples will then go through a flow cell in a sheet of fluid, and then one by one they will go through this flow cell, and they will be lit by a laser beam. And the light dispersion that these cells are showing will then be used to determine their own characteristics. So the forward light scattering will be used to measure the cell volume. So the bigger the scattering, the bigger the cell is going to be. The side scattering will then highlight the cell content, such as the nucleus and granules. So the more complex the samples are, and if they have more lobules in their nucleus, if they have granules, then it will place them on, they will be more complex and they will be classified differently. And these analyzers also use side fluorescence light, which will use the amount of nucleic acids and cell organelles that were bound by a fluorescent dye, and it will also give an idea on the contents of these cells. All of this, what it will help us generate is an automated differential count. And to do so, what the analyzer algorithms do is they, based on this size and complexity characteristics of these cells, it will place the cells into scattergrams. So based on clusters that have been defined by the manufacturer, it will place them on specific sites on a scatter plot. So you would see, as an example, the lymphocytes as a small cell with no granules, and a mononuclear cell with no lobules. It's a cell that it's not very complex or big, so it will be placed here in this part of the plot. But then if you think on neutrophils and basophils, that they have plenty of granules and nuclear lobulation, they are placed, if you think on the site scattering and the higher complexity of the cells, they are placed further to the right. So what the analyzer will read all these cells, and then will place them into these specific spots, and then we would know based on this if we're in the presence of a normal scattergram, like what we see here in the left, or in another situation, and this is pretty much an overlay of this scattergram with a few more other things, if the analyzer started identify cells as being slightly outside or completely outside of these ranges, of these clusters, it will start calling them other things. So you can see here in the neutrophil basophil cluster, if you start seeing cells appearing here in this location, then the analyzer will say there is a left shift here in this sample. Even more, if it keeps on projecting and seeing events being populated in this area of the scatter plot, it will say that there are immature granulocytes. And when they say immature granulocytes, it can be metamyelocytes, promyelocytes, myelocytes. So immediately we're talking about cells that are not really supposed to be in a normal, in circulating in the blood of a normal patient, but then the analyzers can flag for their presence. And also here on, you say, atypical lymphocytes, and that are known to have more cytoplasm content, and so they will be marked as in this area. So the analyzer will be able to let us know in this sample there are some abnormal cells, and this will help us immensely into directing our strategy in, do we need to look at a blood film? What are actually we going to be looking for in a blood film? So this is this flagging that the analyzers do it's a precious tool that in a matter of minutes, we have all this information, and then we can then proceed with follow-up tests if need be. I would like to talk about this WPC channel that these analyzers have. So this is only available in this XN20 analyzers. And WPC stands for white progenitor cells. So it is known that the lipid membrane of the carcinogenic or the blast cells is different. The permeability is different than in a normal cell. So what Sysmex has done is that they developed this method where they have a specific fluorescent dye that is put in touch with these cells, and then the blast cells will absorb more of this fluorescent dye. And what this will do, it will allow us to differentiate better between abnormal lymphocytes or blasts that they would appear here in this specific scatter plot that is produced by in this specific channel. And what the analyzers do, and they do it in an automated way, is if they flag when doing a normal standard full blood count, if they flag for abnormal lymphocytes or blasts that could be located in these areas here, what it will do is automatically reflects a run using this white precursor cell channel, and it will help us identifying, are these abnormal cells that the analyzer is seeing, are they blasts or are they atypical lymphocytes or abnormal lymphocytes? And this makes our life a lot easier and efficient in deciding what sort of strategy should we be choosing, or which priority should we be employing when deciding which blood films to look first. Because a sample that is flagging for blasts should be looked for in the first place, or with a higher priority, so in case we're talking about potential new leukemia, we can address it in a faster way with a shorter turnaround time. So in terms of the strategy that we employ in the lab, so to make sure that we're providing a safe service and that we're aligned with our clinical teams in the service that we need to provide to them, we have we are in the process of developing harmonized procedures across all sites that use the same analyzers and the same patient management system. We already have the same LIMS and patient management software in all sites, which the system that we use is Epic, and we're in the process of updating until the end of the year, all analyses to be in the same platforms across all sites. Having this standardized procedure and harmonized procedures not only gives a framework for our biomedical scientists to work and to know exactly what's expected of them and to abide to the protocols that are meaningful, but also allows us to provide a much more efficient service to our clinicians. We have, as part of these standardized procedures, we have standardized rules for the interpretation of results and interpretation of not only numerical results, but the analyzer flags. We did an in-house study to determine the reference ranges using the analyzers that we currently do, and these ranges, they were discussed clinically with our clinical leads, which in the end led to a harmonized set of reference ranges. And this is very important because then we pretty much can say that for all of our customers, for all of our GPs and doctors working in the hospitals, the way they do the interpretation of the results is the same, no matter if the patient attends a GP for primary care or if they go to a hospital for a procedure and they have the same test done on both sides. The way the result interpretation is done is the same as long as the samples are tested in our laboratories. We also have harmonized criteria for phoning of urgent results, so the doctors know exactly what to expect from us, and they know that we would be phoning them if we find a well-defined set of results that they have been critically signed off. So we have limits, and we know, let's say, as an example, if a hemoglobin is below 70, then the doctors can be expecting that we are going to be phoning them, alerting them that there is this abnormality in the results for a patient. And we also have harmonized criteria for the requesting of blood films, and this is based in the interpretation of our results, and also when to refer patients to specialist hematology doctors. So then they can then provide more advice to the requesting clinicians. And all of these criteria, it has been clinically discussed and it has been approved by our clinical leads. So going into a more practical view of things, so we have, I will present 4 different cases of samples that were tested in the Synovis hub in the blood sciences laboratory. All of these samples, they are from primary care samples, patients that went to their GPs, and they presented to us to have like screening blood tests. And then the actions that we took in the lab allowed us to direct the doctors into diagnosing different types of conditions for these patients. So the first case is from a male patient with 67 years old. As clinical details, we just got the information that the patient was complaining about being fatigued. The patient was known to be seropositive for HIV, and he had a history of other viral infections in the past. And then a full blood count had been requested to assess this patient condition. A lot of the patients that complain about fatigueness, one of the first lines of thought is to think, is this patient anemic? So we tested his full blood count, and the results that we got were pretty much this one. I'm just putting a snapshot of his results. So he had a borderline low hemoglobin concentration. He had a low platelet count, which was significantly lower compared to our lower limit for the reference ranges. We check the sample integrity. Is one of our first checks when we see abnormal results. Is this sample does he have enough volume? Is it clotted? We do these checks, so we release only results that are actually accurate in the context of the sample, and they're technically valid. There was no clots. There was no indication of any issue with the sample integrity. And then the white cell count, including the differential count, they were normal. The analyzer also didn't produce any flags. So let me. And then these are the results from the analyzer. So the scatter plots were absolutely normal. There was nothing abnormal with the histograms other than the platelets, but this might be the consequence of having not that many platelets in the film. There was no analyzer flags as well. It was just this low platelet count that led us to request a blood film to understand what was going on with this patient sample. And then when our BMS was looking at the blood film, they came across an incidental finding. So they saw what it looked to be a malaria parasite, a trophozoite. And I would like just on a side note, we use May-Grunwald Gim staining to stain our blood films, which is a staining method that is optimized for blood film morphology, not necessarily to see blood parasites, including malaria parasites, but we can still sometimes detect malaria parasites with it. The GP had not requested a malaria screening, so they were not even considering to do a malaria screening for this patient. And in light of this finding of these rare blood parasites that were potentially detected, we started doing the follow-up actions. So we referred this sample to the malaria reference laboratory, and we prepared more slides and did some GIM sustain to try and understand if these results would really confirm when looking at a specific method to identify malaria parasites. And this is then what we found. There was actually, with this sort of staining, we were able to see better some more trophozoites, and there were some gametocytes from what it looked like to be a Plasmodium falciparum infection. The patient was then called to A&E. Well, we referred these results to the microbiology consultants, which called the patient to A&E, where he actually told the clinicians that he had recently been in travel to Uganda, and then he started being treated for a malaria infection. And then when we received the results from the malaria reference laboratory, we had a confirmed infection from a Plasmodium falciparum parasites, and with a parasitemia of 0.4%. And then over the following days, the patient had a few more samples taken. He received treatment and then resolved the malaria infection in a matter of days. So this case, what it highlights the importance of having well-defined criteria on how to address numerical results and the actions that should be following based on those results, because this is the case of a patient where we detected something that was not initially what the doctors were actually thinking of, but the low platelet count gave us a hint on something might have been wrong with that sample, and then it led us to identify what was an incidental malaria infection. Moving on to another case, the second case that I'm presenting. It was also a primary care patient. It was, in this case, a female patient with 51 years of age. The clinical details that were provided to us was of an acute shortness of breath. Again, there's a variety of conditions that can lead to this sort of symptoms. The patient had no known conditions recorded in our patient management system, so she was not known to have any health problems at that stage. And a full blood count amongst other blood tests was requested. And when we tested our full blood count, what we saw was a slightly raised white cell count of 17.2, low hemoglobin of 84, and a platelet count of 103. And for these three parameters, if we think of them, none of them would hit or trigger for requesting a blood film, let alone to do an urgent blood film. What we've noted with this sample in particular and with this patient is that when looking at the differential count, the analyzer was unable to count lymphocytes and monocytes, and it generated some flags saying that there was an abnormal white cell scattergram. There were potentially blasts in the sample or abnormal lymphocytes. And this led us to request a blood film and to review it urgently because we had a blast flag coming out from the analyzers. So we can see here in this slide. So on the left, we have the initial run that was done on this patient, and then on the right we have the reflex run using the WPC channel. And what we can see here and the thing that's the most striking with these results is the analyzer couldn't really differentiate between lymphocytes and monocytes that usually sit here, or whatever abnormal population was up here in this upper bit of the plot. So if you look at the differential count here, it didn't even produce a number. It just, there's some dashes here. And then the reflex run, so it just for information, initially flagged for blasts / abnormal lymphocytes. And then when it did the sample with this WPC channel, it was flagging to us that there could really be blasts in this sample. So we took the film and we reviewed it urgently, and this is what we found. The moment we loaded the sample into the microscope, we saw immediately that there was some abnormal cells. So these cells within the red squares here, they were large, they had a significant presence of nucleoli, they had irregular nuclear, the nucleus form was strange, the chromatin condensation wasn't normal as well. And we also saw a little bit of a left shift. So there were some band forms, some metamyelocytes around in the sample, but what we were more concerned about was with this cell type that was here. And you can see it in comparison with other lymphocytes, how larger they are compared with what we call normal lymphocyte, with the normal lymphocyte as we have here. Then we have another picture which pretty much only has those cells and a few normal lymphocytes here, and we can see the difference in size. And I will show in more detail in the next slide how do these cells look like. So in our digital microscope, it classified these cells as blasts, around 50% blasts, and you can see in all of these cells that are presented here, the massive nucleoli, the irregular nuclear form of these cells. You can see that there's a lot of abnormalities going around. There was no cytoplasmic granulation or our rods. So what the biomedical scientist and the hematology registrar that looked at the blood film suspected straight away, is this a case of an acute lymphoblastic leukemia? And then the patient was referred to hematology, followed the initial screening tests and some flow cytometry panels were done in bone marrow aspirates as well. The morphology was also assessed. And what actually we saw in this case, and it was pointing us into what we thought was an acute leukemia, was actually there was a predominant phenotype in the bone marrow. And then in conjunction with the assessment of the morphology in the bone marrow and the presence of blasts in the marrow and the quantification of those blasts, what it was considered that it was this was actually the case of an aggressive chronic lymphocytic leukemia, and is actually being queried to be Richter syndrome. So we're still waiting for some cytogenetic tests to confirm the results for this patient, but it showed that looking at the analyzer flags and the scatter plots and the interpretation that we made of those allowed us to identify what it is, an aggressive type of leukemia, and then allowed us to quickly get this patient referred initially to the hematology doctors, and now the patient has been followed into one of our ESL laboratories. So the patient, I think, is now an inpatient at Guy's Hospital. For the third case that I'm presenting, we have again a GP patient, a female patient with 21 years of age. The clinical details that we saw were just loss of consciousness. There was not much context to it. Again, a full blood count and another set of blood tests were requested, but I'm just focusing on the hematology side of things. So the full blood count showed a white cell count of 14, again, slightly raised or higher reference limit for the reference range. It's 9.6. The neutrophil count was borderline low, so our lower limit is 1.5, but there was not much concern with this neutrophil count. But then the lymphocyte count was raised. So we requested a blood film because the lymphocyte count was 10.2. Hemoglobin concentration was slightly low, and the platelet count was normal. So the main reason for concern with this sample was actually the high lymphocyte count that led us to request a blood film. So when we looked at the results from the analysis, and a little bit similar to what we saw before with the previous patient, the analyzers were having difficulties into differentiating between lymphocytes and monocytes. So it painted these populations in gray. It highlighted us that there was something that was abnormal with this scattergram, and then it also flagged for abnormal lymphocytes when it used the WPC channel. So in this situation, the analyzers were, according to their algorithms, excluding the presence of blasts, and they were more saying that these lymphocytes, they don't look normal. So then when we did our blood film, and when we got to look at our blood film findings, we saw these atypical lymphocytes, and you can see that they have this cytoplasmic extensions with a lot of basophilic color, so dark blue color. They looked quite reactive, which led us to think that it could be an infection. So we referred this blood film to the hematology registrars, which then made they were thinking the same way as we did, thinking that it could be a viral infection. So we'll have a look at in all the blood tests that had been requested in the first phase, and then they were showing that the liver function tests, they were raised, some of them. So all the liver enzymes, ALT, AST, and the alkaline phosphatase, they were raised. Total bilirubin was raised. thyroid tests were normal. Their iron studies were slightly low on iron and transferrin saturation, which could explain the low hemoglobin that this patient had, and their renal function was normal. And then the doctors followed it up with a virology screen that showed that this patient had positive IgM and IgG antibodies for Epstein-Barr virus and a low level of IgM for CMV. So at this stage, it was considered that this low level could be a cross reaction between caused by the presence of the Epstein-Barr virus antibodies, and what it was thought of this, what it was then confirmed for this patient is that she had an infection, viral infection by Epstein-Barr virus, which is a highly contagious virus spreading via saliva, coughing, and sneezing, sexual contact, sharing of objects. There's not really a cure for this infection. Usually the treatment consists in controlling the symptoms. And it's an infection that in the future could be associated with other complications. But the main take for this particular case is the full blood count results and the blood film abnormalities led us to do further investigations and to then get to the correct diagnosis of this patient. And the pathways that we have in place allowed it for a quick escalation of these results and follow-up procedures. And for our last case, we have another situation from a GP patient that came to us, a male patient with 49 years of age with not known reported conditions. And his full blood count results, they were showing some abnormalities. So the white cell count was absolutely normal. There was no issues even with the differential count. But then he had an anemia. So he had a hemoglobin of only 92 grams per liter. And then he had a significantly raised MCV that was our trigger to go and look for the blood film on this patient. And some of the red cell indices, they were also abnormal. So when we looked at the results from the analyzer, the main abnormality that we could see in terms of scattergrams and histograms was that the red cell histogram showed that there was a white peak here. So we could see, and this is probably linked with the high RDW that the patient was showing, so the red cell distribution width, showing that there was probably cells with different shapes and sizes in the sample. And then it was also shifted to the right. So meaning that this peak here, it's compared to a normal sample, is highlighting that there is a lot of samples that are macrocytic, so they have a bigger volume, and this is a reflection of the high MCV. And then when we looked at the blood film, the main feature that looked abnormal to us was the presence of hyperlobular, hypersegmented neutrophils. So you can see that there are here some neutrophils that are showing 7 or more lobules or segments in their nucleus. And this led us to think that we could be in the presence of a vitamin B12 deficiency. So we went to look into other results from this patient, and we could see that this patient was deficient in vitamin B12. His folate levels were normal, but then the features that we saw in the blood film and they were triggered, the blood film review was triggered by the high MCV. They led us to identify that this patient had a vitamin B12 deficiency, and that was what was causing his vitamin B12, his macrocytic anemia. He also had a little bit of red blood cell fragments in the blood film, which can be found also in vitamin B12 deficiency cases. And once again, what this case proves is that if we act on the limit levels and the trigger levels that were defined and that we have in place in our laboratory, then we are able to provide a relevant service and provide relevant results that lead to quick escalation to the appropriate clinicians and to identify clinical conditions that are affecting the patients. And this is done by just doing a screening test, which is a full blood count, that if we know how to do the correct interpretation of results, it can give us a huge amount of information that will direct us into diagnosing the patients. And this would be, and just for your information, kind of the way or rationale behind looking into anemic results, like we have with this last case, results of anemia, the different strategies that we can follow, then based on the tests that we provide with the presence of reticulocytes or not, and how the red cells look like, if they're hypochromic macrocytic or normal or macrocytic, the different pathways that we can follow to diagnose or to direct doctors into diagnosing certain conditions. So what I would like to have as the final take for this presentation that I'm done is to focus on the crucial role that primary care can have in patient diagnosis and management in due time and in a way that is accurate and it's meaningful for both clinicians and for the patients. And the 4 cases that I presented, the aim of those cases was for me to show that the correct technical and clinical interpretation of the results is pretty much a stepping stone in providing meaningful and safe pathology services for the patients that we serve. And then it is really important, and it is a fundamental step, that we have staff working in the lab that understand the results, they understand how they're generated, they understand how the interpretation of the results should be followed, so we can then be accurate with the results that we provide, and we help out the clinicians that have requested these tests. And then also, my last take is that the integrating all these results into having an integrated LIMS system where we can see the results from all specialties and having all this information available to us, it's also fundamental to provide a more efficient patient management and diagnosis. And those are the main takes that I would like to share from more experience as Synovis and from what we do in hematology, in the routine hematology lab, and the service that we provide to our patients. And thank you for your attention.
Thank you, Hui. That was